Assalamu alaikum. Uh, so the remaining part of the chapter, cytotoxic anti-cancer drugs, um, is topoisomerase inhibitors and other miscellaneous drugs, which are very important in some kind of cancers. And in this lecture, we have to discuss these remaining drugs, including topoisomerase inhibitor. Basically, the topoisomerase is the enzyme. It is the nuclear enzyme that altered the shape of supercoiled DNA, and without the action of topoisomerase, the double helix would not be tangled to permit DNA replication, the RNA synthesis, and DNA repair. How this enzyme topoisomerase basically works in altering the DNA configuration? The question is here, and to answer this question, it is very important to understand that it make a cut in the DNA strand which permits the strand to relax in the vicinity of the cut. Later, it can reseal the cut. So there are two types of topoisomerase, known as topoisomerase 1 and topoisomerase 2. The topoisomerase 1 makes the single strand cut, and topoisomerase 2, as the name indicates, makes the double strand cuts. And the topoisomerase inhibitor drugs basically are of two types, and they are grouped in two groups. And the first group contains the topotecan and irinotecan, while which inhibits the topoisomerase 1, and the other group in which etoposide and teniposide, which inhibit the topoisomerase 2. Action of these drugs are somewhat likely with anti-tumor antibiotics, that is the intercalation or alkylation of the DNA. So topoisomerase is the enzyme which involves in intercalation of DNA, and its inhibitor basically work is same as anti-tumor antibiotics. Now come towards the topotecan. Topotecan is the inhibitor of topoisomerase 1, bind to the DNA topoisomerase 1 complex, and it basically accumulate the DNA with multiple single strand cuts. These single strand cuts are not harmful, but if the drug is removed, these cuts may be repaired. So it is very important to administer the drug during the replication of DNA while the drug is still present at that moment. Then irreversible double strand breaks will be produced, and then ultimately causing the cell death. So we have to say that this topotecan is as phase specific drug. The therapeutic uses is it is used for metastatic cancer of ovary, and it is also approved for cervical cancer, that returns after previous treatment or that is resistant to treatment. It is also approved for relapse or refractory small cell lung cancer. Toxicity include the bone marrow suppression. In 98% of the patients, neutropenia occurs, and anemia and thrombocytopenia are also common. Because of myelosuppression, we have to monitor the complete count of blood cells. And if the neutrophil count is below 1500 cells per millimeter cube, topotecan should be stopped. Other side effects include alopecia, nausea, vomiting, diarrhea, stomatitis, abdominal pain, and headache. Another drug is irinotecan. Irinotecan is very similar to topotecan in the case of mechanism of action, that is, it inhibits the topoisomerase 1, and as a result, DNA replication is impaired. This drug is also cell cycle S phase specific, and it is approved for first line treatment of metastatic colorectal cancer in combination with fluorouracil, and in second line treatment of colorectal cancer that has progressed despite treatment with fluorouracil alone. Metabolic activation and activation through an active metabolite SN38, and adverse effects include severe diarrhea. Early diarrhea occurs in 50% of the patient, while late diarrhea occurs in 88% of the patient. Early diarrhea can be suppressed with IV atropine within 24 hours of its onset, while the late diarrhea should be treated immediately with loperamide. Fluid and electrolyte should be replaced as needed. Myelosuppression is also common along with neutropenia and anemia. And along with diarrhea and myelosuppression, introtecane can cause nausea, vomiting, asthenia, alopecia, abdominal discomfort, anorexia in more than 50% of the patients. Other common adverse effects include fever and weight loss, and less common side effects include stomatitis, dyspepsia, headache, cough, rhinitis, insomnia, and rash. So, two more drugs which is grouped into topoisomerase 2 inhibitor. And first of all, in this group is etoposide is very important. It is a drug derived from podophyllatoxin, a naturally occurring plant alkaloid. This is another plant alkaloid, and it inhibits topoisomerase 2. This topoisomerase 2 form making double strand break in DNA, and it does not prevent the enzyme from releasing those breaks, so the cell death occurs. This is occurs in S and G2 phases, and we may call as that is the cell cycle phase specific in S phase and G2 phase for etoposide. The drug is approved for refractory testicular cancer and small cell cancer of the lung. Administration is PO or IV. Protein binding is high. CNS penetration is poor. Etoposide elimination by hepatic metabolism and renal excretion, so the dosages should be adjusted in the patient with liver or renal failure. Major dose limiting toxicity is bone marrow suppression. Other toxicities include alopecia, mucositis, and rarely peripheral neuropathy. The other adverse effects include nausea, vomiting, diarrhea, and fever. Hypotension can also occur with rapid IV administration. So, organic diluent is the main cause, uh, which is used to solubilize etoposide. So, hypotension can be avoided by diluting the drug in sufficient IV fluid. The another drug is teniposide, which is very similar to etoposide in the mechanism of action, that is the inhibition of topoisomerase 2. Only approval indication is refractory acute lymphoblastic leukemia of childhood. Administration is by slow IV infusion. Plasma protein binding is enormous. CNS penetration is poor. Elimination by hepatic metabolism and renal excretion. Adverse effects are bone marrow suppression, hypersensitivity reaction, and secondary leukemias may develop within 8 years of initial drug exposure. Other toxicities include nausea, vomiting, diarrhea, and alopecia. Now, miscellaneous cytotoxic drug in which the asparginase is a drug which is basically act as an enzyme, and it converts aspargine into essential amino acid, that is aspartic acid. By this conversion, the drug deprives cells of aspargine needed to synthesize protein. Although not all the cells are affected, only the cells which include in leukemic lymphoblast, these are affected by this enzymatic drug asparginase. So, um, the drug is indicated in leukemic lymphoblast, and this is selectively act on G1 phase. So, we all know that during the cell manufacturing, the protein histones are required, and normal cells are able to replace aspargine that asparginase took away. So, only the cancer cells are affected, which is associated with acute lymphocytic leukemia. If asparginase is combined with prednisone and vincristine and perhaps daunorubicin or doxorubicin, to make the regime of acute lymphocytic leukemia. Administration is IM or IV. Distribution is restricted to vascular system, not widely distributed. And drug does not cross BBB and indicate inactivated by serum protease. It has severe adverse effects due to the spectrum of toxicity different from other anti-cancer drug. By inhibiting protein synthesis, drug can cause coagulation deficiencies and can injure the liver, the pancreas, the kidneys. Symptoms of CNS depression are also ranging from confusion to coma, developed in 30% of the patients. Nausea and vomiting can be intense and may limit the dose that can be tolerated. Because asparginase is a foreign protein, hypersensitivity reaction are common. Fatal anaphylaxis can occur, hence facilities for resuscitation should be immediately available. In most of the anti-cancer drug, asparginase does not repress the bone marrow and does not cause alopecia, oral mucositis, or intestinal ulceration. While other drug is pegaspargase, it is very much similar to asparaginase. Read it at your own. The, for discussion, the important drug is hydroxyurea. Hydroxyurea inhibits DNA replication by suppressing synthesis of DNA precursors. And this drug inhibits ribonucleoside diphosphate reductase, the enzyme that converts ribonucleotide into their corresponding deoxyribonucleotide. In the absence of deoxyribonucleotide, DNA cannot be made, and hydroxyurea is also S phase specific. The indication include chronic myelogenous leukemia, also used for squamous cells carcinoma and recurrent or metastatic inoperable carcinoma of the ovary. Hydroxyurea can relieve symptoms and prolong life in patients with sickle cell anemia also. Hydroxyurea is rapidly absorbed after oral dosing. Unlike most anti-cancer agent, hydroxyurea crosses the blood-brain barrier with ease. Part of each dose is metabolized in the liver. Parent drug and metabolites are eliminated primarily in the urine. Principal dose limiting toxicity is bone marrow suppression. Um, the drug may also cause nausea and vomiting and dysuria. Neurological deficits and stomatitis may also occur, but these are rare. Hydroxyurea is teratogenic in experimental animals, so the use in pregnancy is limited. Metotane. Metotane is the structural analog of insecticides DDT and DDT, and it is very selectively toxic to adrenal cortex cells, both normal and neoplastic. So, indication is approved only for adrenocortical carcinoma. Administration is per oral, 40% is absorbed, distribution wide, CNS absorption is poor. Because of storage in tissue, primarily in fat, drug remains in the body for weeks after dosing has ceased. Elimination is by hepatic metabolism and renal excretion. The toxicities include CNS depression, nausea, vomiting, and because metotone injures the adrenal cortex, adrenal insufficiency is likely to cause. So, the adjuvant therapy by glucocorticoids is also prescribed. The adversities include dermatitis, visual disturbances, orthostatic hypotension, and renal damage, manifesting as hematuria, hemorrhagic cystitis, and albuminuria. Metotane does not cause the toxicities associated with most other anti-cancer drugs, that is bone marrow suppression and GI ulceration, alopecia, or so on. Procarbazine. Procarbazine is another drug which undergo conversion to active metabolite in the liver. The metabolite alkylate DNA and thereby suppress synthesis of DNA, RNA, and protein. Ultimately, the death of the cell occurs. It is cell cycle phase non-specific. Kinetics include the oral dosing, rapid and extensive hepatic metabolism. Active metabolite are highly lipid soluble, crosses the blood brain barrier with ease. Procarbazine and its metabolite are excreted primarily in the urine. The use, the therapeutic use or indication is very important about the procarbazine as it includes the regime of Hodgkin's disease. It is indicated for Hodgkin and non-Hodgkin lymphoma and primary brain cancer. For Hodgkin disease, procarbazine is combined with miclorethamine, vincristine, and prednisone in the so-called MOP regime. MOP is the very important regime, MOPP. M stands for miclorethamine. O stands for oncovin, the famous name of vincristine. P is procarbazine, which has read here, and another P is prednisone. So for Hodgkin disease, the MOP regime is very famous, and procarbazine is the member of this regime. Formerly, the regime of choice is newly diagnosed patient. Toxicity include bone marrow suppression, nausea, vomiting, and other effects include peripheral neuropathy, CNS depression, secondary leukemia, sterility, especially in males. This drug, procarbazine, should not be combined with CNS depressant like barbiturates, phenothiazines, and opioids. And ingestion of alcohol can induce disulfiram-like response. So procarbazine inhibit monoamino oxidase, so there is a risk of severe hypertension in response to sympathetomimetic drugs, tricyclic antidepressant, and tyramine-rich foods. Another drug is dacarbazine. Dacarbazine undergoes activation in the liver. The precise mechanism of cell kill is unknown, so the evidence is only found is alkylation of DNA, inhibition of DNA and RNA synthesis, and interaction with sulfhydryl groups on protein. The dacarbazine is considered cell cycle phase non-specific. It is principally indicated in metastatic malignant melanoma and Hodgkin disease. Kinetics is very clear. That is, the drug is given IV, CNS penetration is poor, elimination by hepatic metabolism and renal excretion. Toxicity include bone marrow suppression, nausea, vomiting, and cessation of treatment is required when the nausea and vomiting occurs in most of the patient. Other toxicities include flu-like syndrome, hepatic necrosis, photosensitivity, and burning pain along the injection site. Last one is oltretamine, hexamethyl melamine, and it is indicated for palliative therapy of persist or recurrent ovarian cancer. And the other information uh, will be read by yourself. There is no important, not so important and significant thing which is very important to discuss here. So it's all about the chapter cytotoxic anti-cancer drug, in which we have read about the classes of anti-cancer drugs: alkylating agent, antimetabolites, antitumor antibiotics, mitotic inhibitors, topoisomerase inhibitors, and other miscellaneous drugs. I hope you will find it informative. And if there is any query, ask in uh, WhatsApp group or in comment section or directly in the class, in the physical class. Thank you. That's all about cytotoxic anti-cancer drug. Allah Hafiz.